Hi everyone, this is Laura Nolan again from the MESSUP project. We're going to go ahead and get started. I just want to say thank you to everyone for attending this webinar today. We're really excited to be able to offer this information to you. I'm going to start by introducing our two very knowledgeable presenters. First, you'll hear from Sharon Dow, Director of the MESSUP project, who has more than 30 years of experience in policy development, substance abuse treatment, state systems, and technical assistance delivery. She has served as Chief of Policy and Planning for Maryland's Alcohol and Drug Abuse Administration, Program Director for the Joint Commission, and for two federally funded technical assistance contracts, focused on the education and training of addiction professionals. Welcome, Sharon.
Hello, how are you?
Next, we'll hear from Dr. David Wanser, Co-Director for the Center for Sustainable Health and Care at JBS International. Dr. Wanser offers more than 35 years of experience in HIT, healthcare reform, and behavioral health. He leads a national program to support 49 federally funded HIT grantees in selecting and implementing tools and strategies to improve workflow and staff preparation, supporting patient engagement throughout technology, and using data for quality improvement and clinical decision support. Welcome, Dave.
Hello.
Hi. Nice to have you with us.
Thank you.
So next, I'm going to take just a quick moment to describe the functions of this webinar, particularly for those of you who are new to WebEx. On this slide, you'll see that callout number 1 depicts the session window. This is where you'll be able to see the PowerPoint presentation and all the interactive WebEx features to the right-hand side of the screen. Callout number 2 depicts the navigation panel, which is where all of the interactivity, like chatting and answering questions, will take place during the presentation. Callout number 3, at the top right of the screen, highlights the participant panel, which includes a list of all webinar participants. By using the chat feature highlighted by callout number 4, you can chat with other participants and ask the presenters questions throughout the presentation. Questions will be addressed by the presenters in the order in which they were received. Finally, we wanted to point out that the presenters will ask you several questions throughout this presentation, which you'll have a chance to respond to using the polling tab highlighted by callout number 5. Please try and answer the polling questions as quickly as possible, and we'll tally your results for everyone to see. We'll practice how the polling function works on the next slide with some help from our first presenter, Ms. Sharon Dow. Sharon?
Good afternoon, everyone. You should see a polling question on your screen that is actually designed to help us determine whether or not you have ever participated in an interactive webinar before. You have a choice of yes, no, or some of you may not be aware of the answer, in which case you will choose don't know. You have approximately a minute to complete this poll, and when it is completed, we'll know exactly how many of you have had previous experience. Okay, it looks like most of you so far have had previous experience in using an interactive webinar. For those that have not, I'm sure by the time you get to the end of this webinar, you will have learned a whole lot and be willing to do it again. The first thing we're going to discuss is what this particular webinar is. The webinar is going to provide a brief overview of how healthcare is changing, the National Strategy for Quality Improvement in Care, how healthcare delivery may be changing in your state, why healthcare information technology is essential to quality healthcare, and what issues are specific to opiate treatment providers. The webinar is based on a similar one that was provided back in October of 2013. Based on the evaluations of that first webinar, we are going to try to address information that is more specific to OTPs. However, this webinar is not about whether or not the juice is worth the squeeze, one of my favorite phrases, or in other words, whether or not it is worth investing in HIT. That is a decision that will be left up to the leaders of your organizations. It is not going to provide state or provider-specific information regarding electronic health records. It will talk to you about what's going on in states in general, but will not be a state-by-state assessment. It is not a format for conducting an organizational assessment. You will understand later that you'll need to conduct one, and that will be an additional step. Lastly, this webinar is not about how to select a vendor. There are any number of vendors out there and available, and later in further technical assistance, you'll have more information about how to select one. If you need additional technical assistance once the webinar is over, you can log on to www.ehrsforotps.org, which is an electronic health records portal for collaborative learning, or you can call the Medical Education and Support Services to Opioid Treatment Programs TA contract at 800-839-6120. When you call, please ask for Rosa Neal or Melissa Ferranda. I am now going to turn the next portion of our webinar over to Dave.
Well, good afternoon, everyone. Thanks for joining in, and I hope as we go through this, if you do have any questions, that you'll please submit those, and we'll try to get to as many of them as possible. This webinar is going to provide a lot of information, so my apologies up front. We're going to zoom through it and really want it to be as useful as possible, but there's so much territory to cover that it's hard to squeeze it all into an hour. You know, the challenge before us is that healthcare is changing pretty rapidly, and there is, in this changing healthcare system, a really dramatic shift toward a focus on patient engagement and data-driven decision-making. And it's important for us to understand the use of these tools of patient engagement and data-driven decision-making around some of the structural changes that will be taking place. In every state, there will be some move toward expanded use of something called an accountable care organization, which is a large network of different kinds of providers that are at some level of risk, financial risk. There's health homes. There's different components of an expansion of integrated care. In some cases, that's through a managed care and, again, risk-based environment. And, of course, we've got parity playing out at the same time as expanded insurance coverage is taking place under the Affordable Care Act. So where we're going to focus our attention here is looking at the core competencies in the use of health information technology. So it's a step beyond implementing it. It's how to use it, and then how to really get yourself ready to anticipate the upcoming changes that are forthcoming. You may have heard of the Triple Aim, the National Strategy for Quality Improvement in Healthcare, and it gets at the high level, better care, affordable care, and making for healthier communities. And beyond that immediate set of goals, it's really focused on how we make care more patient-centered, and you're going to hear that term a lot here today, more reliable, more accessible, and safe. And what that means is that we will have to have figured out ways at the provider level, at the actual interaction with client level, about how to really do a better job of getting through a whole set of outcome measures and quality metrics that will now be associated with all providers of healthcare. So our first poll question here is, who should and who does in your organization address physical health risks with patients? And you can please push the appropriate button and then push submit, and we'll get your answers.
It looks like most of you have chosen the answer C, that the entire clinical staff including the counselors, are the people at your programs which address the physical health risks for patients. Dave is now going to discuss with us other priorities in healthcare.
And I need the bouncing ball to come my way, please. Okay, National Strategy for Quality Improvement in Healthcare. That you probably have heard less of this than the triple aim, but the National Strategy for Quality Improvement establishes 6 priorities, and you see them here. What's interesting about this is that as we started on this road toward improved healthcare, and it was kind of the basis of the goals and objectives of the Affordable Care Act, you know, the initial case was how do we make care safer? And fewer medical errors obviously was a part of that. And some estimates of the cost of medical errors go as high as 35% of total healthcare costs. But what became increasingly apparent is that what really makes a difference is engaged patient and families, and that entails effective communication and coordination of care. It really speaks to how do we make people healthier, and that involves things that go well beyond what happens in a physician's office or in a treatment program. It's really how do we engage communities, and then how do we make the care that is available more broadly accessible and affordable through these new healthcare delivery models. And we're going to talk about the extent to which healthcare delivery really becomes much more mobile and much more ongoing and interactive than it's been in the past. So for the most part, what we've had in the way of healthcare provision is really something that hasn't changed much. And we're trying to get to a holistic view of the person. This is, you know, I think many of us have said, well, we think about the whole person. We know there's no segregation of mind and body. But the actual rubber meeting the road on that is changing how the actual care is delivered. And increasingly, we're seeing this term interprofessional teams. And medical schools are now training medical students and nursing students to work in interprofessional teams that might entail a whole range of different specialty providers, including behavioral health providers. So the delivery system is morphing in pretty significant ways to bring in substance abuse treatment providers, people with mental health expertise into the actual physical healthcare delivery system and be a part of an ongoing team that communicates regularly, that divides responsibilities for helping that individual patient and their family to improve their health outcomes. So how does this impact us in the way our system operates today? You know, one of the important parts of this, of how the system's changing, is where the changes are taking place. And the issues that are really driving attention to holistic care play out more at the state level, really, than they do at the national level. And what we see around the country is different legislative mandates that are articulating how that individual state is going to proceed with the Affordable Care Act. Now, in some states, what we're seeing is the kind of all-in philosophy where the governor and the legislature says, well, we want to do all this. We want to do everything that needs to take place to improve care for the populations in our state. The structural, and then there's other states, of course, where the politics are not in that direction, and they're trying to avoid the term Affordable Care Act and trying to limit how that's implemented. But nonetheless, they're still coming up with strategies that look very similar. They're looking at building networks, at requiring quality metrics, at narrowing who can deliver care, and passing risk on to provider systems. And those financing models, the risk-based models, are really becoming much more prevalent, and they will become much more prevalent as we go forward. So here's a question that gets at this notion of treating the whole person and integrated care. In your organization, what kinds of co-occurring health conditions impact the total cost of health care for the individuals you serve? And if you go ahead and answer that, the key term there is the total cost of health care, because what we find is that we tend to think about health care in our silo. So it's what is the cost of health care for somebody in a substance abuse treatment program? What's the cost of that same person that might be going to a cardiologist? What's the cost of care for that person that might have diabetes, but not the whole person? And the kind of shifting models, these accountable care organizations, the health homes, really start to get at the total cost of care, because those risk-based contracts are going to be incorporating estimates of the total cost of care for the person. So it makes that issue of how much care costs much more critical for every provider that ends up being in one of those networks, because they're going to have to judge that from their own perspective. So what you've answered here is that all of the above is the most common occurrence. And, the fact of it is that puts you in a very important position relative to managing the total cost of care of that individual. There are some states that are allowing and encouraging for health homes to be operated by behavioral health organizations. There's other states where we're seeing those health homes or accountable care organizations developing capacity within their own system, within their own organization, to deliver a full range of substance abuse and mental health services, up to and including opioid treatment programs. So what might we need to change at the ground level in our organization? I think for the most part, very little has changed or been engineered. Certainly very little has been re-engineered over the last 50 years in these areas. There are a lot of different assessment tools that people favor for the same set of issues. There's extensive use of free text in how we document. Documentation is often redundant. Data systems oftentimes collide with clinician practice habits. So we really don't pay attention to treatment plans as something that is developing a clear path for helping that individual adhere to a plan that will help improve their health and wellness. Almost all data is input by clinicians and not patients, and increasingly we'll find expectations that patients are supplying information. We're going to talk about that a little more as we go on. And we really struggle with sharing data across systems, both in terms of our electronic health records or other technologies being interoperable, but also a willingness to partner across systems, and particularly with the healthcare system. And then we really haven't done as full-blown job as we need to around addressing health risks and health issues and helping people to overall address their wellness. And maybe one of the best examples of that is tobacco use. Many organizations now, or substance abuse treatment organizations, are starting to incorporate tobacco cessation programs as a core part of their treatment approach. And I'm going to talk a little bit more about why that's important in just a little bit. So the important question is, do you know how healthcare is going to be changing in your state? And as I said earlier, these tend to be things that play out at the state level. So here's kind of a checklist of things that are commonly occurring across many states. In some cases, you can go down this list, and in a particular state, they'll have every one of those things. The only one of these things really that's on the national level is meaningful use. But most states are developing some form of accountable care organizations. What's interesting about that is that initially the CMS model, and they selected 70-some-odd accountable care organizations to be Medicare-focused accountable care organizations. They were all hospital-based. And within just a few short years, the shift is now to community-based networks being the locus of these accountable care organizations. So there's now more large FQHCs and large physician health practices that are becoming accountable care organizations, and there are hospitals. And there's a growing number of Medicaid accountable care organizations, outnumbering the Medicare ones at this point. And we're also seeing insurance companies of all kinds, both public and private, starting to look to this model as a way to help control costs and improve outcomes. Health homes, similarly, the health home model as it's articulated for Medicaid is really a pilot project, so it's only got about another year to run. Some states have focused a lot of attention on that, and I expect it might continue beyond that one more year. Every state, and in some cases local providers and local groups, have developed health information exchanges. In large states, we see multiple ones of those. In small states, they tend to be just one. Many states are developing all-payer claims databases, and what that helps helps for policymakers and purchasers to do is to understand the total cost of care, because oftentimes people have coverage across different insurance plans and fall in and out of Medicaid, for example, and so it ends up being difficult to know what the total cost of care is. And those are rich data sources, and many, many organizations now are looking to develop analytic capabilities so they can mine that data. There's something called a beacon community, and CMS funded a bunch of those over the last several years, and they're really kind of centers of excellence for treating complex conditions, and there may be one or more of those in your state. You can look online and just Google beacon communities and find out where they are, but they oftentimes have published a wealth of information around different tools they've used, clinical guidelines they've used, outcome metrics, and so forth. About half the states are doing Medicaid expansion at this present time. I expect some more will come on board in the next few years. There's a lot of opportunities with that, but the Medicaid expansions in almost every case are being done through these structural models that I've been mentioning. The health insurance exchanges we've all heard about relative to the rollout last October of healthcare.gov. But the health insurance exchanges will on an annual basis be enrolling people to join plans, and those plans will be on an annual basis looking at their networks and looking at the benefit packages. And so if you interact with or start to realize the importance of interacting with insurance companies, you'll want to keep very tuned in to what they're doing with benefit packages. The MMIS, Medicaid Management Information Systems, are all changing so that they can start to incorporate both the claims data, which is where they've always focused, but quality data, with the goal of being able to link that claims data and quality data within a single claim. And that gets to be a very, very important part of not only your electronic health record capabilities, but also your organization's staff capabilities of managing those outcomes throughout the patient's experience in your organization. And Meaningful Use Stage 2, which is the incentive program for electronic health records, will be one of the places where those quality metrics are required. So when we talk about these quality metrics, what does that mean? What does that involve? I'm going to tell you. These are the health home quality measures, and they will be required of anyone that's a health home. And I'm not going to spend a lot of time going through these, but I just want you to get a sense of the mix within these of both mental health and substance abuse measures with primary care. And so organizations, primary care organizations, are going to have to be attending to these issues. Behavioral health organizations of all kinds, including yours, will have to start saying, well, how are we going to track some of these things? Because we, too, will be part of networks where we're going to have to pay attention to care transitions. We're going to have to pay attention not controlling high blood pressure. Here are some specific measures that you're used to. These are the measures that are specific to OTPs. And, you know, I'll look at, if you look at the bullets here, particularly the third and fourth, you know, these are the places where you've had your focus on health-related conditions. But I think as you'll see the rest of these measures I'm going to go through, that the level of detail of that and the broadening expectation for reporting those things in a more timely way, in a more immediate way, are going to continue to accelerate to the point where in a few years we'll be sending in a claim, but also that payer will be able to look into a database and see if you're achieving the goals and the outcomes according to their established expectations. This is the National Quality Forum's endorsed behavioral health quality measures. There will be an effort over the next few years that has already been started to homogenize, I guess the best word, all of these different measures that are now out there for quality. And you know, what I'm doing and showing you this is that there are so many different of these measures from different sources. You know, the National Council on Quality Assurance, the American Medical Association, Centers for Medicaid and Medicare Services. You know, they've all established these things. There's now kind of a national cry for let's come up with one set that everybody signs off on. Center for Medicaid and Medicare Services and the Office of National Coordinator for Health IT, or ONC, has endorsed these measures. And what we'll see is, again, you've got this connection between behavioral health issues, risky behavior, physical outcomes, and those things just are increasingly going to be aligned.
Okay, our next poll question has to do with how knowledgeable you are about the concept of clinical decision support and how it would be operationalized. Please take a moment and think about this and think about whether or not you understand it pretty well, whether you have some idea about what's involved, and whether you have not much of an idea about what's involved. It's totally to the point of saying, what? There is information that you normally collect, such as drug test results and attendance and use of other drugs that assist you in making clinical decisions, especially when you think about issues such as take-home or moving through the various phases of treatment. It looks as though most of you have some idea about the whole concept of clinical decision support. Dave?
Thanks, Sharon.
The poll is still closing, so we're going to just take 1 minute here to get the results to you, and then we will go on to the next slide.
The reason this will be relevant is, as I talk next about this issue, it's going to play into selection of electronic health records and how meaningful use plays out. So what we see is kind of an interesting spread. You know, some proportion of you, about 17%, think you've got a pretty good grasp on it. 42% have some idea. 21% don't have much of an idea at all, and another 21% have not responded. So I guess we're losing people's attention span. So I'm going to try to bring you back, get you more focused on this about why health IT is essential to quality health care. And this gets to be the critical part of how this plays out in your organization. There's no escaping the extent to which all of health reform in every single component of the Affordable Care Act is going to be requiring extensive use of data, real-time, individually focused. It's going to have to be patient-centered. You're going to have to be measuring things related to patient engagement. You'll be looking at how interprofessional teams share information. You're going to be expected to use evidence-based practices. All of those things start to play out in this new environment of health reform. So how do we start to use data? And in particular, how do we use real-time decision support tools? And the things that will be start being routine expectations is you're going to use those. You're going to use it to manage treatment adherence. And you know, We have oftentimes talked about treatment plans, at least I've heard people talk about treatment plans as a requirement that the state imposes on people or that the accrediting organization imposes. We tend to look at failures of treatment plans as the client's fault, and we tend not to do a very good job of realizing that why treatment plans fail oftentimes is we've expected things of people that they can't or won't do, and we haven't tailored it to what they can do and then giving them the tools to manage adherence to that plan. Expectations to share data will become more common and basically an expectation you can't avoid. Electronic health records will have to incorporate structured data taxonomies and be able to electronically generate and individualize patient education materials. So to get a sense of where you're at with that term I use, structured data taxonomy, would you please quickly respond just off the top of your head about whether or not you know what a structured data taxonomy is? And this is really an important issue because the structured data taxonomies will be necessary for us to be able to share data in such a way that the receiving party is aware of what the sending party intended them to see and how to interpret that data. So let's take just a couple more seconds before we find out how that goes, and then if everybody knows what this is, I'll zoom through the next couple slides, and if not, I'll take a little bit more time to try to explain. This will also get to how you use information in your own organization. I've talked about it just from the standpoint of sharing it and being able to interpret it, but it also gets at being able to have much more richer clinical information, much more nuanced clinical information within your organization. So almost 2/3 don't know what a structured data taxonomy means. So that is helpful to know. I'll spend just a little bit more time on that. And let's start with terminology challenges. William Farr, back in 1839, made the observation that each disease has in many instances been denoted by 3 or 4 terms, and each term applied to as many different diseases, and that those terms are vague, inconvenient, or been employed, or complications have been registered instead of primary diseases. And this gets at this real challenge of specificity in describing what is it that's going on with that individual at this time that requires treatment. Now, you're all familiar with the ICD-9, the ICD-10, even though the ICD-10 now has been pushed back just recently for some longer amount of time, even though the rest of the industrialized nations have been using ICD-11 for several years. We still haven't managed to get ourselves wrapped around ICD-10. But the problem with ICD-10 is this is not a structured data taxonomy. It's really something that has been built up around things that people have used to bill for. And so you get really screwball things that might not occur very often, but there's a code for them. So you see what some of those are here. You can fall into a bucket of water that causes drowning and submersion. There's a raft of these. There's things like being pecked by a chicken, bitten by a duck, intentional self-harm caused by a paintball gun, a balloon collision, and even crushed by a crocodile. I hope that none of these things have ever happened to any of you. But what a structured data taxonomy is a set of standardized terminologies for storing patient information. The most complex of these, and the one least known, is called SNOMED. It's the standard nomenclature of medicine, clinical concepts, clinical terms. LOINC is the standard data set for laboratory values and RX norm for medications. What's happening is that electronic health records in many cases over the years have been kind of built to that vendor's specifications rather than a national or international data standard. The data standard that's being used for the continuity of care document, which is the packet of information that will be used to share information through health information exchanges, uses another standard called Health Level 7, or HL7. You may have heard of that one. That's probably more generally known. But what's important about that is that these kinds of terminologies will increasingly become really the expectation for electronic health records. Certainly by the time we reach meaningful use stage 3, that will be a part of the expectations that we'll see around being able to be certified as an electronic health record. So what this all requires is that we start to have a better focus on the kinds of information that we see that helps inform adherence to treatment. We start to look at lifestyle assessments. So, you know, if you don't currently look at sleep patterns, exercise patterns, nutrition patterns, those are the kinds of things that will need to be incorporated. Screening for a whole range of health conditions. I didn't have it up here, but the Prevention Services Task Force has identified 50-some-odd health risks, and electronic health record vendors now are building in algorithms to help you define what kinds of health risk assessments people that you're serving need to have so that you can do early intervention and preventive care. So it's really starting to change the dynamic around reactive care to proactive care. And then being able to do medication reconciliation, which I think all of you probably are also attuned to relative to what other medications patients might be taking that you're seeing. And then just listening to them and being aware of how they're doing relative to following treatment recommendations. This graphic kind of gets at where the next generation of electronic health records needs to end up. It looks at, on the left box there, you see kind of the legacy electronic health record or even paper record content. It's, you know, demographics, lab, meds, those things. What you see on the right is this patient's reported information, the ability of patients to put information into an electronic health record through a portal. I apologize that the arrows aren't bidirectional because they should be. Clinical guidelines are built from the wealth of data that we are collecting through health information exchanges, through all payer claims databases, through other large databases around shaping at a more individualized level recommendations for treatment. So what comes out of this mix of data, some of which is traditionally collected by providers, some supplied by patients, some imposed through what we know about what works, you get to an individualized clinical recommendation. And this gets to be really incredibly important because it needs to be worked into your workflow. And what you want to be able to have at a glance within the amount of time someone's in front of you, and I know that you all have managed workflows for a long time. You have to see a lot of people quickly. You've got to make decisions. You've got to get them through the process. But you also want to have that encounter give you the opportunity to provide some level of supportive intervention for things that may be health risks and beyond the immediate kind of purpose of the visit. So you want to see a summary of what the individual's current condition is. You want that clinical decision support tool to direct you toward a step to take if that's necessary. You want to be able to know how you're doing as well as how that patient's doing. And then you want that to be presented in the electronic health record, so at a glance, you know what your step is and what you need to do. And increasingly, we're seeing mobile technologies help inform that, whether it's patients using their smartphones to supply information on a quick questionnaire before they get to your office, whether it's you sharing reminders to them about appointments or medication refills. But really, it gets at this last bullet, which is, you know, the expectation that we try to communicate with folks 99% of the time that they're not in your office. It's not sufficient to think that a periodic visit is enough to help them adhere to complex treatment conditions that they need to work on. So here's an example from a diabetes set of labs where, if this pops up in your electronic health record, and I use this just because, and there's different formats for these things, but I used it to show you that you've got very quickly on the left-hand side, things that are green, things that are red. Do something about the things that are red. And it takes just a second for the provider to see that, to know what they need to do, to put that in motion. And that's ultimately what we want an electronic health record to help us with. We don't want a lot of clicks. We don't want to have to open and close windows. Here's another example of something that a clinic supervisor could pull up. This could be drilled into by the individual provider. So if I was looking at my panel of patients I saw and I wanted to know, well, how many of these folks are current cigarette users, I'd have an overall distribution. I could look at it by gender. I could look at it age group, ethnicity, and then I could drill into that and say, well, how many females that are of childbearing age that are African American are smokers, and are there interventions that I could look at that might be specific to them? And this helps start to shape us, shape our direction much more toward having, the kind of focus that we would hope to see around individualized patient education. So we're going to talk a little bit about understanding health IT. And I think we've all heard the High-Tech Act, about whatever that means, and people aren't quite sure in many cases what it means, but the High-Tech Act is what many folks thought, and their interpretation of it was, means everybody needs an EHR. That, and probably 10 years ago, actually George Bush's picture would have been there. 12 years ago, he was the one that started this. But the idea would be that that was really at that time the end point instead of the starting point. And the Health Information Technology for Economic and Clinical Health Act, which was part of the ARA funding, really incentivized providers to implement the electronic health records, but the incentives were such that there was also expectations that those electronic health records would eventually be able to be certified to a much higher standard than what we've seen in the first generation or even second generation of EHRs. And meaningful use was kind of the guideline that drove a lot of that. And where this is important is that stage one, which was the stage that's now ending, really got at just the ability to capture and transmit screening data. So you could, I've mentioned the tobacco quality measure previously. You can screen and say, of the people that I see, I've screened 24% for tobacco use, and then you could submit that even through an email because it didn't require any patient health information, and say to your payer source like Medicaid, we've screened 24% of our patients for this reporting period, and that would be good enough. So most EHRs had that functionality, just to basically pull up an email, pull up a summary of the raw numbers. Stage two requires that data to be going through your electronic health record to a health information exchange to a payer. So this is where we start to see the introduction of these standardized data taxonomy. So the HL7 messaging would be the vehicle through which you were to do that, but the bar also gets raised around not only screening, but then of the ones that screen positive, how many did I intervene with? And this will play out across all those different quality metrics. So if it's, women of childbearing age or postpartum depression screening, whether it's medication adherence screening, it will be, these are the ones I screened, these are the ones that I intervened as a result of that screening. Stage three, which starts 2016, is much more exciting because then you're sending the health information through your electronic health record to the health information exchange, and the health information exchange makes that information accessible to a payer. and they start to connect the quality metrics with payment information. And so in that case, you start to see this is where the report card gets to be relevant. You've screened a certain percent, you've intervened with a certain percent, but as a result, I've achieved this outcome. So it's a big leap forward in terms of how we can demonstrate that we've achieved an outcome. And what you're going to want your electronic health record to do is to let you know how that's going on a regular basis. So if you think about the slide I showed you previously around being able to profile the people within your caseload, this is why this is relevant, because you want to know on an ongoing basis how you're doing, what your grade's going to be, and you want to know that before your report card comes out. So this notion of the broadening use of electronic health records to report to health information exchanges, that these quality measures will start to be applicable to all, even though they initially started to play out with limited utility or limited use, limited focus to health homes or to physicians that participate in the Medicare program. Insurers are paying very close attention to this, and I think as we start to see a uniform set of quality measures, that we'll start to see all payers of all kinds start to connect those. I know many state substance abuse agencies are now looking at these measures and thinking about how they can incorporate that into performance-based contracts. So there's really a progression here that is important for you to see, and it's a good kind of metric, simple metric to say, where are we at in terms of our organization's use of health information technology? And this is kind of a maturity model. You know, you can kind of look at where you're at right now, but ultimately level 5 should be your goal. And you should use this and other things we're going to talk about in the very near future here to really start to get at how does this play out within my organization, how does it inform my future expectations around what I purchase in the way of electronic health records. So how many of you now have the ability to share client information through a health information exchange and are currently doing so too? So please, yes or no, or unsure. Unsure is probably a no. And then we'll take a look at that. Okay, it's probably pretty good in terms of being able to close this poll.
Okay, we just need 1 second. The poll takes a little bit of time to close, so we'll be with you shortly.
Okay, here it comes. Okay, 58% are not, 13% are. Well, actually, if we take 51 and 8%, 58%, 8%. So about 2/3 of you are not, 13% are. So, you know, there's those of you that are not are going to have to figure out a plan to get there, because as the people you're serving start to have opportunities to be participant either in Medicaid programs or insurance programs that are covering OTP services and methadone, Suboxone, other kinds of treatments, you're really going to find that it's in your best interest to have that capability. And any electronic health record that meets the meaningful use stage 2 requirements are going to have that capability. So one of the things that oftentimes is a barrier, perceived barrier at least, to folks participating in health information exchanges are HIPAA regulations. There's a new set of those. They're much more rigorous than the previous ones. This extends the risk to business associates and their subcontractors for liability. It gives individual patients the right to obtain electronic copies of their records So that may not be something you've had to deal with in the past, but I was in an organization recently that had about 20% of their patients in the first 6 months of the last 6 months of last year had made requests to see their records electronically. So as clients become aware of this, you'll start to see those requests. There's also an enhanced right for people to restrict the disclosure of their personal health information, and a change in the breach notification rule that says any disclosure of personal health information is presumed to be a breach. So what that means is if you've got a copy machine that you use to print off faxes or information from patient health records, and that copy machine's hard drive contains some of that information, as all copy machine hard drives do these days, and you've leased it or you sell it and you've not erased that hard drive, that's a breach. Doesn't mean that somebody had to see it. It just means that it has to have been exposed to the potential for someone accessing that personal health information. So it's a higher bar than we've had before. And before I leave that, the other thing is that organizations now will have to start doing security and confidentiality, security and privacy assessments, risk assessments. That's a whole other complex topic that that's an area where all of you that have electronic health records and are using personally identifiable information will have to do security audits within your organizations. We're all familiar with 42 CFR Part 2. It was enacted well before the internet came to be, so there's a lot of issues there with how this is going to play out relative to the consent specifications as they currently exist, and then how do we deal with this whole issue of redisclosure. So if you send something through a health information exchange from one person to the other, but the health information exchange can look at party B and party C has requested that information, it starts to be very hard to follow the train on how this information is being used. There, I think, will be increased pressure on SAMHSA and others to open up 42 CFR and to figure out how that's going to work in this new world of accountable care organizations. So we're almost done. Just a few more slides, and we're going to talk about readiness assessment. There's really the importance of the next few slides is to really emphasize that health reform readiness, health information technology readiness, and organizational capacity are all so interwoven that you can't separate them. You can't say, well, I'm just going to look at my health reform readiness without also looking at these other two, and vice versa. And really it gets at answering the questions of, do I know what I need to do? Do I have a vision for where I need to be in the next 3 to 5 years? So one more poll question. Based on your current and planned implementation of electronic health records and your notions of how you might participate in new care delivery models, what additional assistance might you need? And we're going to use this information to help tailor some of the information that we put up on websites, some of the future webinars, other resources that we make available. So it's going to be helpful to know proportionately how many of you kind of are focused on these various areas. And please go ahead and do that. This will be a very important piece of information for us. So I hope those of you that may not have been participating in the poll will put your 2 cents worth on this one.
As you're answering the poll, you may also want to think about what other issues are specific to OTP providers. A lot of times we are not aware of the Affordable Care Act and how it affects our communities, or whether or not there is actually an effect in our communities. We feel threatened by some of the more non-traditional providers. There's even a section of accreditation standards that ask you to talk about non-traditional methods of treatment, and most organizations aren't comfortable dealing with that. tackling the most difficult aspects of change, which means a whole different way of doing business. Some of you are already Medicaid providers, but a lot of you are not. You're cash only, and this is going to involve a whole different way of doing business. So you're going to need to think about what are your biggest unknowns, what are the threats to how you currently do business, and how those threats can be turned into opportunities, and how would you rate your comfort level with various aspects of preparedness. We are finished the poll now, and it looks as though the vast majority of you do plan to upgrade or to select an EHR at some point in the future. Dave will now talk to you about engagement.
You know, and I think it's also relevant that about a third of you decided not to answer this, and I'm not going to try to interpret that, but these things will all be things that you're going to have to be addressing. So in particular, even as you look at upgrading or selecting an EHR at some point in the future, thinking about how that plays out with implementation of meaningful use, the stage 2 requirements. You know, certainly anyone that's buying an electronic health record these days needs to have something that's already certified for stage 2. I was working with an entity recently that their stage 1 certified EHR vendor had lost their certification because the functionality that they had wasn't deemed to be sufficient, as they made some additional changes to their programming or their code. So stage 2 is very critical, and then how, you know, very detailed questions about the capability of your electronic health record to handle analytics. 4% of you said that your organization is in pretty good shape, so I think it's relevant that 96% of you might need to look at these set of issues. You know, are you prepared to be fully aware of ACA? Are you understanding these threats, as Sharon said? And then this is not an easy thing to do quickly. So preparedness is going to take time, and starting way before you think you need to start is always a good plan. So the first issue of 6 is engagement, and really being able to start to measure how effectively you're engaging with a person from the point where they first call to make contact through their treatment episode, and even helping support them into ongoing recovery supports after they leave. This is increasingly something that will demand improvements to your workflow, really looking at this whole notion of how much time is expended between somebody calling to schedule something and us actually initiating treatment. We know that the more quickly those two things occur in sequence, the better likelihood that someone's going to adhere to treatment and stay engaged in treatment. And then are we looking at individual staff performance regarding their ability to help individuals engage and stay engaged in treatment? Asking questions about quality and efficiency and whether or not your electronic health record will support those functions. You know, is it going to help you with consumer-directed care? Will you be able to exchange information? Will individual clients be able to put information into a portal that shows up in their electronic health record? Are you going to be able to export information for quality reporting? And will you have the level of analytics that allow you to ask questions on the fly and get information? Or does your vendor require you to use a package of canned reports that is pretty limited in its functionality and its ability to individualize and profile different patient groups? And then, you know, workflow and process improvement is always related to implementing an electronic health record, upgrading an electronic health record, because it always impacts workflow, and design of that workflow is a really critical piece. Change management is oftentimes a challenge. This is, you know, you hear people say the hard stuff is the soft stuff. Change in organizations is not always embraced, and I think being able for leadership to be involved, for there to be careful planning, attention to project management and execution, and then database decision making. The workforce issues, I think I've been to a whole bunch of organizations lately that have tried to introduce mobile technologies and gotten a good deal of pushback from their staff who aren't comfortable with that, either as a mode of delivery, aren't comfortable with technology, don't like the notion of telehealth services, and really it's not acceptable for organizations not to have technology-capable staff. And you're going to have to deal with external networks, those relationships with healthcare providers. Some of you may have had long-standing relationships, or you might even be part of a healthcare organization. Others have not. So I think that's important. Knowing how to manage technology projects as you expand the use of mobile technologies, as you start looking at the use of portals, you start looking at how telehealth might help in between appointment times if someone needs a consult, and then looking at non-traditional partners, people that may not have been part of your networks previously. Patient-centered care. This whole notion of providers being accessible much more than when scheduled appointments are made and being able to answer questions is now becoming the new normal for how healthcare is delivered, which means that the provider on a kind of 24/7 basis needs to have access to information about that particular client and access for information about patient education or referral sources or other things. And you certainly all know that increasingly you should be able to access those things off of a smartphone or a tablet. It requires a different set of interpersonal skills. I work with a good number of folks that do telehealth, and it's a whole different dynamic to do a telehealth session than it is to do an in-person session. Follow-up care needs to be much more proactive, and we need to reach out to people around that using technology. Patient education needs to be much more individualized and specified, and then we need to start incorporating guidelines and best practices, not only about the specific thing we're doing, in this case relative to opioid treatment, but much more broadly around all those other health risks, diet, nutrition, exercise, smoking, and so forth. And then last but most important is really having a data or information strategic plan. You need to have an idea about what you need technology to do for you and really have a roadmap for how you're going to get there, and recognize that these kinds of things you see listed here will be part of what will have to happen. So purchasing technology with the future in mind. People do a terrible job, frankly, of selecting EHRs. More often than not, they will base their decision based on how good of a job the marketing person works for the EHR vendor does, so convincing them that they've got a good product. They don't do a thorough vetting of that product, and the result is a good deal of dissatisfaction with that product. So, in summary, these requirements are intertwined. You have to deal with quality reporting. Holding ground won't work, and you have to look at how your electronic health record requirements are going to be changing around payment, particularly risk-based payment, eligible populations, and care coordination. So how complicated is it to do? It's actually pretty complicated. It doesn't mean you shouldn't do it, but think about this from the standpoint of a matrix, and this is what our Center for Sustainable Health and Care focuses on, is this matrix that involves the vulnerabilities you see at the bottom. And these are things that will be facing all organizations. No organization can say, well, I'm fully prepared to deal with payment reform, data integration, data exchange, process improvement, and culture change, because the full picture of how that's going to play out over the next few years is not yet in sharp focus. But it cuts across your organizations in terms of governance, strategic planning, financial capacity. So it's a complicated set of requirements, but again, it's so critical that you all do this kind of readiness assessment within your organizations.
Okay, now it's time for additional questions. Some additional questions that you have, you'll be able to get answered by getting technical assistance, and information regarding future TA is on your screen. The other thing is that right now, if you have additional questions, please unmute your phone or use the chat function in the lower right-hand corner to ask any questions that you have. Please don't be shy. We would like to hear from you. I know that earlier we had a question asking for a further explanation regarding clinical decision support. Dave, could you give some more explanation regarding that, please?
The VA North Texas healthcare system, with facilities in Dallas, Fort Worth, Bonham, and Tyler, wants to help you stay healthy. The following will help you enjoy the healthy life you as a veteran deserve.
Somebody put us on hold.
Did you know that less than half of U.S. adults get
We're working on muting the lines for those that might hear a little background noise, so just bear with us one moment.
From even small amounts of activity, you should avoid.
That was an example of a clinical decision support advertisement, really. It's that, you know, wellness messaging through whatever means is possible. That was somebody that had it on their phone so that when someone called into the organization and they were waiting, instead of hearing music, they heard a wellness message. Clinical decision support is really very broadly applicable to the use of information to improve a clinical outcome. And very few organizations have ready access to that level of information. You want it to be something, if you remember that graphic I showed earlier, something that shows up in your electronic health record as you're seeing the individual. It helps improve your decision making. Really, the ultimate goal of an electronic health record should be to make you smarter. If it has the functionality that helps form better care, that's really the critical part of that. Other questions? Okay. Rosa, do you want to Sharon, I'm sorry, do you want to wrap up?
Yeah, Dave, this is Rosa. I will wrap up. I just wanted to thank everyone again for participating in the webinar. If you would like some additional information or some technical assistance, you can reach us at 1-800-839-6120 and get those on the screen. If you have any more immediate questions, now is the time to ask while we have an expert event.
Rosa, thank you very much. There was a question regarding whether or not there is financial support or grants that would be available to small OTPs. Dave, do you know of any grants? I know there was a grant program that was put out about a year ago. I haven't heard anything else. Do you know of any grants or other financial support, especially for small organizations?
You know, in regard to getting assistance with, selecting and purchasing electronic health records, the funding that has been available, more broadly available, not specific to OTPs, that's helped organizations decide about electronic health records and train staff to use them, has gone through what's called a regional extension center. And these were things that were funded through the Office of National Coordinator for Health IT. Every single state has one or more of those organizations. So if you looked at Regional Extension Center and put in your state's name, you'll see who's available. They have different ways of providing that care, or that service, that consulting. Sometimes it's free, sometimes there's a charge, but it's worth investigating. I'm not aware of SAMHSA having any funding available for that at this point, unless it's incorporated into another grant. So some of the other grants that they're doing, like SBIRT, some of the adolescent grants, criminal justice grants, now uniformly have an expectation that there will be health information technology, that organizations will participate in health information exchanges, and they designate a certain percentage of those grants for that purpose. And then finally, your states have the ability, if you're in any way connected with a state substance abuse agency, they have the ability to request state-level technical assistance. That could be something that was tailored for all of the OTPs within that state around some of these topics.
Dave, an additional question that came down the pike was, does a listing of endorsed EHR exist for OTPs?
No, it doesn't. It doesn't. I think the things that would be critical for you are the certification for stage 2 meaningful use. And one of the critical things you want to do when you select an electronic health record is to provide that vendor. So a part of the selection process, even as a part of the process of narrowing down different providers, is to arrange for them to do a demo, but then at the time of the demo, give them a script and say, show me how it does this, and make that script follow your workflow. So you want to be able to see how they would work through that process so that you have an idea about whether or not that's going to be conducive to the way you conduct your business. So there's no easy, here's the list of the best ones. They all have strengths and weaknesses, every single one of them out there. But the real task is how you select it and doing a good job of vetting the vendor along the lines of the workflow you need and the functionality you need it to perform. So I would look at that, give them a script, tell them to do certain things, be sure that you include in that, compile these analytics, give me this data on the basis of what's in the record. And those two things, taken together are probably the two most critical, and then its ability to provide you a portal or have clients interact with the record would probably be the third. And the fourth would be that it has the capability for being mobile so that you can access the information wirelessly, if that's possible, or even to use offline, so you can do it offline and then sync and upload data on a regular basis. So those are all kind of critical functionalities. It's hard to find vendors that can tick all those boxes, but it's a good beginning place for you.
Dave, another question that was posted says, I'm having difficulty in finding a software that integrates dosing with the functions necessary to also submit billing. Is there assistance in locating that rather than listening to all the companies sell their ware?
There really is not a good single place where you can go and ask questions about those things. I think if you were to seek out the regional extension centers in your state, you might have an idea of what they've come across, because they're the ones that have helped narrow the field in terms of the better functioning electronic health records. But again, it's one of those things you can put into a script and say, show me how your record will do this. And in some cases, in many cases, the vendors will say, oh yeah, we can build that. Well, have them show you how that would actually play out, and make sure the more specifically you say, these are the requirements I need for that. My dosing has to do these 5 things in this amount of time. The better you are able to gauge whether or not they've got the horsepower to make that happen.
Another question that just came in, how would an EMR work for cash only?
I think it's, I think pretty much the same way. I mean, it's, those of you that are cash only can assume that over time your clients won't have access to coverage as they start to get more engaged with insurance and Medicaid. Cash only is pretty much a simple transaction from the standpoint of billing. I think you still want those kind of decision support tools. You still want to be able to look at health risks, because even though the person might be cash only in your organization, they're probably going to be having some kind of coverage that gets them access to a range of other behavioral health services. And at some point, that the availability of those other services and the fact that those other providers are starting to expand their array of offerings may impact your cash business.
A question that came in earlier during the presentation, Dave, referred to just a simple, if there is one, a simple definition around a clinical decision support tool. Could you just clarify that one more time, please?
Sure. It's not just one thing. Clinical decision support are all the components of a record that come together and help you make a better decision. So clinical decision support is knowledge integration. It's all the things that go on. If you think about an electronic health record as a place where you store a bunch of Word documents that doesn't do anything for you, that's kind of the old generation electronic health record. What you want is an electronic health record that has built-in algorithms so that it saves you steps and gives you information that helps you do a better job. So it's that broad statement of all those things. It can involve analytics. It can involve being able to do point-and-click reporting. It can involve the ability to tailor recommendations based on what someone said. There's zillions of examples of how you can help people manage compliance using clinical decision support tools. Some of those go to the individual for patient education. Some of them go to the clinician and predict things that might go wrong with the treatment protocol. There's infinite variety of what that means.
Dave, I'd just like to add, one way of thinking about that in an OTP is that you make decisions regarding an individual patient, such as whether or not that patient gets take-home, or if you give phase treatment, whether or not a patient moves from one phase to another. Well, you don't just make those decisions by saying, I like John, therefore I give him take-home. There are certain behaviors and things with which you want that individual to be in compliance, which makes you move them through those phases or helps you to determine if they get take-home. So what Dave is talking about is using that clinical record to be able to support those clinical decisions. That's something you're currently doing. Therefore, the next phase would be how to incorporate those things into an electronic health record. So you're already practicing clinical decision support. It now needs to be actualized in a different way.
So that it would give you something like a risk probability.
Yes.
If I give this person take-homes, my probability of that person being able to successfully do that is 87%.
Mm-hmm.
And then you can set your own thresholds for that.
We don't have any other questions. I spoke too soon. Will this slide be available outside of this presentation? We'd like to be able to present the information to our owners.
Yes, the whole presentation is going to be available outside of today. We have taped and we'll upload the entire webinar, and we will send everyone who registered for the webinar a link to the webinar that will be on the Learning Portal sometime next week. And you'll be able to just link into it and present it to anyone that needs to see it. Well, if that's all, we definitely thank you for coming. The last poll is a feedback poll. We'd like to know how we did. Letting us know, have a complete evaluation helps us to be able to improve any webinars and presentations in the future. Like I've already said, this webinar will be available in about a week, and the poll will be left open for another 6.5 minutes so that you can complete it. There are about 11 questions, and we'd really like to hear from you. Thank you very much.
Thank you all.